Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 209 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the first question reads, MDS, a 25-year-old male patient is admitted to your medical ICU for a drug overdose. He requires mechanical ventilation. 48 hours later, MDS developed acute respiratory distress syndrome, abbreviated as ARDS, and he remains mechanically ventilated. By day 4, MDS has signs and symptoms of pneumonia, and the critical care team plans to initiate empiric antibiotic therapy. His chest X-ray shows bilateral lower lobe infiltrates. He has a body temperature of 38.8 degrees Celsius, an FiO2 of 50%. A tidal volume 350 milliliters, PEEP is 10 centimeters of water. Pressure support 7. His WBC count is 14 times 10 power 3 cells per liter, with 55% neutrophils, and 5% bands. His nasal swab is negative. Pause the video and carefully scrutinize the antibiogram in this slide. And now my question to you is, which of the regimens listed below would be the most appropriate choice in MDS's current clinical scenario? Would it be A. Cefepime, ciprofloxacin, and vancomycin? Or B. Levofloxacin and vancomycin? Or C. Cefepime and ciprofloxacin? Or would it be D. Piperacillin, tazobactam? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Piperacillin, tazobactam. The pneumonia type is ventilator-associated pneumonia, which is defined as an infection that develops at least 48 hours after intubation. Selection of empiric antimicrobial therapy is based on the presence of risk factors for multidrug-resistant (MDR) pathogens. Coverage for methicillin-resistant Staphylococcus aureus (MRSA) should be provided if the prevalence of MRSA is unknown, if the institution-specific antibiogram demonstrates that greater than 10 to 20% of the Staphylococcus aureus isolates are resistant, or if risk factors for antimicrobial resistance are present. None of these scenarios applies in this case. Provision of single versus double coverage with anti-pseudomonal agents is also based on the presence of risk factors. In this case, the institutional resistance pattern for Staphylococcus aureus to vancomycin and linezolid was less than 10%, and there were no patient risk factors for MDR pathogens, so a single agent piperacillin, tazobactam may be used. Cefepime and ciprofloxacin is not appropriate because there is no evidence to support the use of double gram-negative coverage in MDS. Levofloxacin and vancomycin is not appropriate because there is no need to provide double gram-positive coverage or the use of vancomycin as empiric coverage for methicillin-resistant Staphylococcus aureus. cefepime, ciprofloxacin, and vancomycin is not appropriate because there is no need to provide empiric coverage for methicillin-resistant Staphylococcus aureus or double gram-negative coverage. Please proceed to the next question. And the next question reads, CKF, a 57-year-old female patient was admitted 4 days ago for management of hypercalcemia, shortness of breath requiring mechanical ventilation, acute kidney injury with fluid overload requiring renal replacement therapy. On her chest X-ray, there is evidence of a left lower lobe infiltrate. CKF is currently receiving chemotherapy for breast cancer. She has a past medical history significant for a 10-day hospitalization to treat a central line infection 21 days ago. Her clinical parameters include a blood pressure of 102 systolic 67 diastolic, a HEAR rate of 83 beats per minute, a respiratory rate of 25 breaths per minute, a body temperature of 39.2 degrees Celsius, a WBC count of 12 times 10 power 3 cells per liter, with 55% neutrophils, and 3% bands. Pause the video and carefully scrutinize the antibiogram illustrated in this slide. Based on the current Infectious Diseases Society of America (IDSA) and American Thoracic Society (ATS) clinical practice guidelines for management of adults with nosocomial and ventilator-associated pneumonia, which of the empiric treatment strategies listed below would be optimal for CKF? Would it be A. linezolid, meropenem, and levofloxacin? Or B. linezolid, cefepime, and colistin? Or C. linezolid, aztreonam, and imipenem cilastatin? Or would it be D. vancomycin, piperacillin, tazobactam, and gentamicin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. linezolid, meropenem, and levofloxacin. CKF is at risk for methicillin-resistant Staphylococcus aureus (MRSA) and multidrug-resistant MDR Pseudomonas because of her prior IV antibiotic use within 90 days. Empiric antimicrobial coverage needs to include an agent, such as vancomycin or linezolid, with activity against methicillin-resistant Staphylococcus aureus (MRSA), and dual coverage for multidrug-resistant MDR Pseudomonas. Aminoglycoside penetration into lung tissue is less than that of fluoroquinolones, so vancomycin, piperacillin, tazobactam, and gentamicin is less desirable than linezolid, meropenem, and levofloxacin. Given the patient's renal dysfunction, imipenem cilastatin would not be a viable option. Colistin is reserved for use when the organism is not susceptible to other treatment options. Linezolid, meropenem, and levofloxacin is the best choice given the patient's renal function based on the IDSA/ATS clinical practice guidelines. Please proceed to the next question. And the next question reads, regarding CKF's clinical scenario above, based on the current Infectious Diseases Society of America (IDSA) and American Thoracic Society (ATS) clinical practice guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia, which of the following risk factors for multidrug-resistant pathogens are present in CKF? Is it A. mechanical ventilation, continuous renal replacement therapy, and sepsis? Or B. prior IV antibiotic use and continuous renal replacement therapy? Or C. hospital length of stay and continuous renal replacement therapy? Or is it D. hospital length of stay, mechanical ventilation, and prior IV antibiotic use? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Prior IV antibiotic use and continuous renal replacement therapy. Sepsis at the time of diagnosis is also a risk factor, but this patient does not have sepsis. Mechanical ventilation is not a risk factor for multidrug-resistant pathogens in patients with VAP. According to the IDSA/ATS Clinical Practice Guidelines, prior IV antibiotic use within 90 days is a risk factor for multidrug-resistant pathogens in patients like CKF with ventilator-associated pneumonia (VAP). Hospital length of stay longer than 5 days prior to diagnosis is also a risk factor, but this patient's length of stay is only 4 days. Mechanical ventilation is not a risk factor for multidrug-resistant pathogens in patients with VAP. According to the IDSA/ATS Clinical Practice Guidelines, acute renal replacement therapy prior to diagnosis is a risk factor for multi-drug-resistant pathogens in patients like CKF with ventilator-associated pneumonia. Please progress to the next question. And the next question reads, PKM, is a 54-year-old male patient who was admitted to your hospital 72 hours ago for atrial fibrillation. Regarding his chief complaint, he feels achy. On admission, PKM had no other medical issues. Today he has a productive cough. His pertinent vitals include an oxygen saturation on room air of 87%, a WBC count of 13 × 10⁻³ cells per liter, and a body temperature of 38.7 degrees Celsius. Diagnosis of pneumonia is made by the clinical team. Based on current clinical practice guidelines from the Infectious Diseases Society of America (IDSA) and American Thoracic Society (ATS), which of the following specific types of pneumonia is present? Is it A. ventilator-associated pneumonia, or B. healthcare-associated pneumonia, or C. community-acquired pneumonia? Or is it D. hospital-acquired pneumonia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. hospital-acquired pneumonia. According to the IDSA/ATS Clinical Practice Guidelines, hospital-acquired pneumonia occurs 48 or more hours after hospital admission when there was no evidence of infection at the time of admission. PKM's pneumonia is considered hospital-acquired because he was admitted 3 days ago without signs or symptoms of pneumonia. PKM's pneumonia is not community-acquired pneumonia because he is in the hospital and had no signs or symptoms of infection prior to admission. Healthcare-associated pneumonia has been removed from the IDSA/ATS Clinical Practice Guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia. This designation will be re-evaluated when the IDSA/ATS guidelines on the management of community-acquired pneumonia are updated. Ventilator-associated pneumonia occurs in patients who have been mechanically ventilated for at least 48 hours. PKM has not been mechanically ventilated. Please proceed to the next question. And the next question reads, BGS, a 60 kg, 57-year-old female patient with acute myelogenous leukemia post-induction chemotherapy presents to your accident and emergency department. Her pertinent vitals and labs include a heart rate of 148 beats per minute, a respiratory rate of 26 breaths per minute, a blood pressure of 82 systolic 58 diastolic, a body temperature of 39.5 degrees Celsius, a WBC count of 0.1 × 10⁻³ cells per millimeter cubed, hemoglobin of 7.9 grams per deciliter, a platelet count amount of 12 times 10 power 3 cells per millimeter cubed, an INR of 2.7, a lactate of 7 millimoles per liter, a BUN of 41 milligrams per deciliter, and a serum creatinine of 2.4 milligrams per deciliter. So my question to you is, which of the time frames after diagnosis of septic shock listed below is the most appropriate for the initiation of broad-spectrum antimicrobial therapy for BGS? Is it A, 6 to 12 hours, or B, 3 to 6 hours, or C, 1 to 3 hours? Or is it D, 0 to 1 hour? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, 0 to 1 hour. This patient has febrile neutropenia with septic shock. Early initiation of broad-spectrum antimicrobial agents is associated with better survival than later initiation in patients with febrile neutropenia. The time frame of 0 to 1 hour after diagnosis is ideal for a patient like this one with febrile neutropenia and septic shock. Although a time frame of 1 to 3 hours would be considered early for initiation of broad-spectrum antimicrobial agents in patients with septic shock, survival was not better than with a 0 to 1 hour time frame. Although 3 to 6 hours would be considered adequate for initiation of broad-spectrum antimicrobial agents in patients with septic shock, survival was not better than with a 0 to 1 hour time frame. Higher mortality is associated with initiation of broad-spectrum antimicrobial agents after 6 to 12 hours than earlier initiation in patients with septic shock. Please proceed to the next question. And the next question reads, which of the therapies for hypercalcemia of malignancy listed below is associated with the highest risk of hypercalcemia? Is it A, pamidronate, or B, calcitonin, or C, denosumab? Or is it D, zoledronic acid? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, denosumab. In a randomized, double-blind study, hypercalcemia-related adverse events were more common in patients treated with denosumab, that is 10.8%, than patients treated with zoledronic acid, which is 5.8%. Bisphosphonates, including zoledronic acid and pamidronate, are associated with a slightly lower risk of hypercalcemia than denosumab. Calcitonin has an early onset of action in reducing serum calcium in patients with hypercalcemia. However, tachyphylaxis occurs after several, that is longer than 2 days of treatment, and hypercalcemia is uncommon. Please progress to the next question. And the next question reads, which of the following statements comparing IV pamidronate with zoledronic acid for the management of hypercalcemia of malignancy is true? Is it A, pamidronate 90 mg lowers serum calcium faster than zoledronic acid 8 mg? Or B, pamidronate can be administered faster IV than zoledronic acid? Or C, pamidronate 90 mg is less expensive than zoledronic acid 4 mg? Or is it D, the response to pamidronate 90 mg lasts longer than the response to zoledronic acid 8 mg? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, pamidronate 90 mg is less expensive than zoledronic acid 4 mg. The duration of response to zoledronic acid, that is 32 days for 4 mg and 43 days for 8 mg, is approximately twice as long as for pamidronate 90 mg, which is 18 days. Pamidronate 90 mg is approximately 20% less expensive than zoledronic acid 4 mg. Zoledronic acid can be administered intravenously over 5 to 15 minutes. By contrast, pamidronate is infused over 2 hours. In two identical, concurrent, parallel, multi-center, randomized, double-blind, double-dummy studies of patients with hypercalcemia of malignancy, a serum calcium is less than or equal to 10.8 mg per deciliter, i.e., normalization of serum calcium, was achieved by day 4 of treatment with zoledronic acid 8 mg in 56% of patients and pamidronate 90 mg in 33% of patients. Thus, normalization of serum calcium was faster with zoledronic acid 8 mg than pamidronate 90 mg. Please proceed to the next question. And the next question reads, which of the times listed below are appropriate for re-evaluation of empiric antibiotic therapy for febrile neutropenia in high-risk patients, e.g., patients with hematologic malignancies, and low-risk patients, e.g., patients with solid tumors, based on the median time to defervescence in these patient populations and results of blood cultures? Is it A, 11 days and 7 days, respectively? Or B, 8 days and 5 days, respectively? Or C, 5 days and 2 days, respectively? Or is it D, 2 days and 1 day, respectively? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, 5 days and 2 days, respectively. These time frames are unrealistic because most blood cultures require a minimum of 1 day for significant growth before results can be reported to the healthcare team. The median time to defervescence is 5 days in high-risk patients with hematologic malignancies, including hematopoietic stem cell transplantation, and 2 days for low-risk patients with solid tumors. These are appropriate times to re-evaluate empiric antibiotic therapy based on the results of blood cultures. 8 days and 5 days, respectively, time frames are too long. 11 days and 7 days, respectively, time frames are too long. Persistent fever alone in a patient whose condition is stable is rarely an indication to alter the antimicrobial regimen. Clinical judgment about whether the patient is responding to the initial antimicrobial regimen is more important than defervescence when considering modifying therapy to provide appropriate coverage. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 210.